Neurotransmitters and neuroreceptors are some of the highest yield and most dreaded topics on the PRITE and Psychiatry Boards. In this video, you will be answering questions you used to feel were impossible. Let's begin with the three monoamines because they are the foundation of psychiatric pharmacology. First is dopamine. So dopamine is synthesized from tyrosine, and you do need to remember the pathway of dopamine synthesis. So this goes from tyrosine to L-DOPA to dopamine to norepinephrine to epinephrine. Boards absolutely love asking about the different dopamine pathways, so we are going to spend a lot of time on them. Dopamine originates primarily from the substantia nigra, which is very high yield, and the ventral tegmental area, also high yield. Its major functions include reward, motivation, movement, cognition, and prolactin inhibition. Next is serotonin. Serotonin is synthesized from tryptophan, and you do need to remember that. Many students remember this from Thanksgiving turkey. Serotonin originates from the Raphe nucleus, that is also high yield. Think mood, anxiety, appetite, sleep, aggression, impulse control, and sexual function when you think of serotonin. A good way to remember this is turkey rest for serotonin. Finally, there's norepinephrine. Norepinephrine is synthesized directly from dopamine, and it originates from the Locus Coeruleus, one of the highest yield nuclei on the boards. Norepinephrine is responsible for attention, alertness, arousal, and the flight or fight response. Locus Coeruleus sounds a lot like locus of panic, which is how I remember it. Think anxiety and hyperarousal when you think of norepinephrine. We are going to spend some extra time on dopamine because the four dopamine pathways are among the highest yield neuroscience topics. First is the Mesolimbic pathway, which runs from the VTA to the nucleus accumbens and limbic system. This is the reward and salience pathway. Too much dopamine here is associated with positive symptoms of schizophrenia, including hallucinations, delusions, paranoia, and disorganized thought process. And antipsychotics improve hallucinations and delusions by blocking the D2 receptors in the Mesolimbic pathway. That is incredibly high yield for your boards. This pathway is also central to addiction because drugs of abuse increase dopamine signaling in the nucleus accumbens. That is also high yield. Second is the Mesocortical pathway, which runs from the VTA to the prefrontal cortex. This pathway is involved in cognition, executive function, motivation, and emotional regulation. Too little dopamine here is associated with the negative symptoms of schizophrenia. That is very high yield for your exam. It is also associated with cognitive symptoms, including poor working memory, impaired attention, and executive dysfunction. A clinical pearl that you really need to know is that the D2 blockade may worsen negative or cognitive symptoms because it can further reduce dopamine activity in the cortex. Third is the Nigrostriatal pathway, which runs from the substantia nigra to the striatum. This pathway controls movement. So blocking dopamine here causes EPS symptoms. Clinical pearl that you do need to know is high-potency first-generation antipsychotics like Haldol have the highest risk of EPS symptoms, and Parkinson's disease is caused by degeneration of dopamine neurons in the substantia nigra, leading to decreased dopamine in this pathway. Make sure that you remember those for your exam. Fourth is the Tuberoinfundibular pathway, which runs from the hypothalamus to the anterior pituitary. Dopamine normally inhibits prolactin release. So when antipsychotics block D2 receptors here, prolactin increases. You need to know the clinical effects of this, which include galactorrhea, amenorrhea, infertility, sexual dysfunction, gynecomastia, and long-term bone loss. You need to know that risperidone is especially associated with the hyperprolactinemia, and Abilify can be used to treat this because it is a partial D2 agonist. Now let's talk about glutamate. Glutamate is the primary excitatory neurotransmitter in the central nervous system, and you do need to know this because the PRITE may ask you which neurotransmitters are excitatory versus which are inhibitory. Think about glutamate as the gas pedal. Now there are two receptors that you need to know. The AMPA receptors are responsible for rapid excitatory signaling, whereas the NMDA receptors are much more complicated and therefore more testable. There are some facts that may show up on the exams that you need to know. First, so the NMDA receptors require both glutamate and glycine to activate. Therefore, glycine is the obligatory co-agonist. Second is at the resting membrane potential, magnesium physically blocks the NMDA channel. Depolarization removes this magnesium plug. And then when the channel opens, calcium enters the neuron. Calcium is important for learning and long-term potentiation, but excessive calcium causes neuronal death. This process is called excitotoxicity. Now let's apply glutamate clinically. Excessive glutamate activity produces excitotoxicity, and that is why we use memantine, an NMDA receptor antagonist, in moderate to severe Alzheimer's disease. Boards also love schizophrenia here. The glutamate hypothesis proposes that the NMDA receptor hypofunction contributes to schizophrenia. The NMDA receptors also explains ketamine and PCP, how they produce hallucinations, negative symptoms, and cognitive impairment in healthy individuals. Now let's talk about alcohol. Alcohol works through two important mechanisms. It blocks NMDA receptors while simultaneously enhancing GABA-A receptors. So alcohol withdrawal occurs because of chronic alcohol exposure causes the upregulation of NMDA receptors and downregulation of GABA activity. So when alcohol is removed, the brain becomes hyperexcitable, and that is why withdrawal causes seizures and delirium tremens. If glutamate is the gas pedal, then GABA is the brake. GABA is the primary inhibitory neurotransmitter in the brain. The GABA-A receptor is a ligand-gated chloride channel, and when the chloride enters the neuron, it becomes hyperpolarized and less likely to fire. Several board medications act here, and you need to know them. Benzodiazepines increase the frequency of chloride channel opening, and barbiturates increase the duration. Alcohol enhances GABA-A signaling, and Z-drugs also work here. One high-yield disease connection that you need to know is Huntington's disease. Patients lose GABA neurons in the caudate nucleus, and without this inhibition, abnormal movements develop. A memory tip that you can use to distinguish Benzos versus Barbs is Ben gets frequent haircuts, whereas Barb keeps her hair long, a long duration. This distinction shows up frequently on exams. Several neuropeptides are worth knowing. One of them is orexin, also called hypocretin, which is produced in the lateral hypothalamus. It's important to note that loss of orexin occurs in narcolepsy. You also need to know substance P because substance P mediates pain transmission. And finally, oxytocin promotes maternal bonding, trust, attachment, and social behaviors. Some studies suggest that it dampens amygdala activity during emotional situations. A couple more that you need to know for your exam is histamine, which originates from the tuberomammillary nucleus. Histamine promotes wakefulness. Blocking H1 receptors produces sedation and weight gain. Think about mirtazapine, think about Seroquel. Acetylcholine is incredibly important for memory, attention, consciousness. Whenever an elderly patient suddenly becomes confused after receiving Benadryl, think about the anticholinergic delirium. Myasthenia gravis is another classic board topic, which includes this neurotransmitter. Patients develop antibodies against the postsynaptic nicotinic acetylcholine receptors. This produces fatigue, weakness, ptosis, and diplopia. Now we're going to transition into the pathological synthesis of major depressive disorder because this may show up on your exam. Now current models include decreased serotonin, norepinephrine, and dopamine signaling. However, there is also increasing evidence that inflammatory cytokines actively increase serotonin reuptake transporters, and this state is associated with decreased natural killer cell immune activity. You also need to know about the major concept of BDNF. So brain-derived neurotrophic factor supports neuronal growth and synaptic plasticity. Successful antidepressant treatment increases the BDNF activity. That also may show up. And finally, you need to know that GABA dysfunction may contribute to mood disorders, particularly in postpartum depression. That is why the neuroactive steroid medications like brexanolone, work through the GABA-A modulation. Boards increasingly ask about the inflammation and neuroplasticity rather than just simply monoamine deficiency. This final table is your one-stop shop for the origins, pathways, and clinical correlations. Make sure you subscribe for new videos every week and check out the other neurology videos for your exam. Good luck.